Welcome to another episode from the Veterinary Medicine Digest. Today, we are embarking on a deep and detailed exploration of a condition that often presents as a frustrating mystery for both feline practitioners and cat owners alike. We are talking about feline inflammatory aural polyps. These are non-neoplastic pedunculated growths that originate from the epithelial lining of the middle ear, the auditory tube, or the nasopharynx. While they are benign, their impact on a cat's quality of life can be significant, leading to chronic ear infections, vestibular issues, and even neurological deficits. To understand these growths, we must first dive into the complex landscape of the feline ear, look at the historical theories regarding why these polyps form, and then examine the latest groundbreaking research that is changing how we view the prevalence and treatment of this condition. To start our journey, we must understand the house these polyps live in. The feline ear is an intricate organ divided into three distinct anatomical and functional components: the outer ear, the middle ear, and the inner ear. The external or outer ear includes the pinna and the external acoustic meatos, serving as a sound-gathering structure. The middle ear is an air-filled bony cavity called the tympanic cavity, which is connected to the nasopharynx by the auditory tube and separated from the external canal by the tympanic membrane, or what we commonly call the eardrum. In cats, the middle ear cavity is uniquely and unequally divided into two compartments by a thin bony septum, giving it a characteristic double-walled appearance. This is a crucial detail for veterinarians to remember, as these compartments, the smaller dorsolateral and the larger ventromedial, play a significant role in how disease progresses and how surgery is performed. Finally, the inner ear structures are housed within the temporal bone and are responsible for hearing and equilibrium. When we talk about inflammatory polyps, we are looking at the most common benign tumors of the feline ear. Yet, despite their frequency, their exact cause remains a subject of ongoing debate. Historically, because these polyps are frequently seen in young cats, often between 1 and 4 years of age, many have suggested a congenital origin. However, another prominent theory suggests they are the result of chronic inflammation in the upper respiratory tract or the middle ear. There is a fascinating proposed pathophysiological course that begins with a simple upper respiratory infection. This infection causes a lymphatic reaction in the mucous membranes. The resulting swelling and frequent sneezing lead to increased pressure in the nasopharynx, which can force the auditory tube to open. This inflammation may then affect the function of the auditory tube, leading to poor ventilation and pressure changes in the middle ear. This environment stimulates a process called metaplasia in the middle ear lining, where the tissue changes to include more goblet cells and intraepithelial glands. As inflammation continues, these tissues proliferate, forming granulation tissue that eventually becomes a polyp. As the polyp grows, it may eventually rupture the tympanic membrane and extend into the external ear canal, where it often becomes contaminated with bacteria. The search for a specific infectious trigger has led researchers to look closely at common feline pathogens. Studies have attempted to detect feline herpes virus type 1, feline calicivirus, mycoplasma species, Bartonella species, and Chlamydophila felis within polyp tissues. The results, however, have been inconsistent. In a pilot study that assayed both clinically normal cats and those with polyps, researchers found that DNA or RNA of some of these agents could be amplified from samples in 25% of normal cats and 33% of affected cats. This suggests that while these agents are present, they might not be the direct cause. It is possible they initiate the formation of the polyp and are then cleared by the immune system or antimicrobial therapy before the polyp is actually diagnosed. When a polyp is present, what does a veterinarian or an owner actually see? The clinical signs are variable and depend entirely on where the polyp is located. If a polyp is in the external ear canal or the middle ear, we call it an aural inflammatory polyp. These cats often present with signs of otitis externa, such as head shaking, ear scratching, and a persistent discharge called otorrhea. If the polyp affects the middle or inner ear, we may see more severe signs. These include Horner syndrome, which involves a drooping eyelid and a constricted pupil, or facial nerve paralysis. Signs of inner ear involvement, known as otitis interna, can include a head tilt, nystagmus, which is involuntary eye movement, ataxia, and even hearing loss. On the other hand, if the polyp originates or grows into the nasopharynx, we call it a nasopharyngeal inflammatory polyp. These cats might exhibit nasal discharge, stertorous or noisy breathing, sneezing, and in severe cases, life-threatening upper airway obstruction. Diagnosing these polyps requires a step-by-step approach. It usually begins with a physical examination followed by otoscopy. Video otoscopy is often preferred because it provides superior illumination and magnification, allowing the clinician to see deep into the canal. Aural inflammatory polyps typically appear as smooth, pinkish to white, rounded masses. They can be soft or semi-firm, and their surface may look dull, ulcerated, or glistening. However, visualization is only part of the puzzle. Because these polyps often cause secondary bacterial or yeast infections, infections, cytology is mandatory to identify the specific organisms involved and guide treatment. To truly understand the extent of the disease, diagnostic imaging is essential. Historically, conventional radiography was the primary tool. Veterinarians would use 5 classical projections, lateral, rostrocaudal open mouth, and left and right lateral oblique views to evaluate the bullae. While radiography is accessible, it often lacks sensitivity and can be difficult to interpret due to the superimposition of skull structures. This is where advanced imaging like computed tomography and magnetic resonance imaging have revolutionized our approach. Computed tomography is widely considered the gold standard for evaluating the bony structures of the ear. It can identify soft tissue opacity within the bulla, thickening of the bulla wall, and even the presence of a stalk-like structure which is highly suggestive of a polyp. Magnetic resonance imaging, while not necessarily superior to computed tomography for identifying the polyp itself, is invaluable for evaluating soft tissues and the nervous system. It can detect meningeal enhancement, which helps clinicians investigate if the inflammation has spread toward the brain, a factor that can significantly impact the prognosis. One of the most important shifts in our understanding of this disease involves how often it occurs in both ears simultaneously. Traditionally, these polyps were thought to be almost exclusively unilateral, meaning they only affected one side. However, a retrospective study at the University of Tennessee over a 10-year period found a prevalence rate of 24% for bilateral polyps. This means nearly 1 in 4 cats had polyps in both ears. Critically, in many of these cases, the second polyp was only identified through advanced imaging like computed tomography or video otoscopy. This underscores the vital importance of checking both ears thoroughly, even if the clinical signs are only visible on one side. Now, we turn our attention to the most recent and extensive research on this topic. A retrospective imaging-based evaluation conducted between 2019 and 2024 at Istanbul University. This study analyzed 154 cats, making it one of the largest cohorts ever studied for feline inflammatory aural polyps. The findings from this research are quite revealing and in some cases challenge our traditional assumptions about this condition. One of the most striking results from the Istanbul study was the age distribution of the affected cats. While we often think of this as a disease of the very young, 53.25% of the cats in this study were mature adults between 2 and 7 years of age. Only about 14% were under 6 months old. The researchers suggested this might be due to the prolonged subclinical progression of the disease, where the polyps are growing slowly without causing obvious signs until they reach a certain size or cause a secondary infection. It also highlights that we should be suspicious of polyps in adult cats, not just kittens. Even more surprising was the laterality of the lesions. In this large group of 129 cats where localization was fully evaluated, 51.16% had bilateral involvement. This is a significantly higher percentage than the 24% previously reported and reinforces the idea that bilateral disease is not just a rarity but is actually quite common. Furthermore, when they looked at the bipartite anatomy of the feline middle ear, those 2 compartments we discussed earlier, they found that in 98.45% of cases, the lesions involve both the dorsolateral and the ventromedial compartments. This means the inflammation is rarely confined to just one part of the middle ear, which has major implications for how we treat it. Speaking of treatment, the goal is the complete removal of the polyp tissue to prevent recurrence. There are 2 main surgical approaches: traction and avulsion, and ventral bulla osteotomy. Traction and avulsion is the simpler method and can often be performed by a general practitioner. Under general anesthesia, the clinician uses forceps to grasp the mass and, with a swift twisting motion, pulls it out. In many cases, the entire polyp and its stalk can be removed in one attempt. To improve precision, some clinicians use a polypectomy snare through a video otoscope, which allows them to cinch the polyp tightly before avulsion. After removal, the area is thoroughly lavaged with sterile saline to minimize inflammation. While traction and avulsion is less invasive, it has historically been associated with a higher recurrence rate, with some studies reporting recurrence in up to 64% of cases. The reason for this is likely that significant amounts of inflammatory tissue and infected material can remain trapped in the middle ear. To combat this, many experts recommend a tapering 8-week course of systemic glucocorticoids like prednisolone after the procedure. This medical therapy has been shown to statistically reduce the rate of recurrence compared to cats that do not receive steroids. The more definitive surgical option is the ventral bulla osteotomy. This involves a surgical approach through the neck to access the bulla directly. The primary benefit of this procedure is that it allows the surgeon to break down the bony septum and access both compartments of the middle ear. This allows for a more complete removal of all inflammatory tissue and a thorough cleaning of the entire bulla. It is often the preferred choice in severe cases for recurrent polyps or when imaging imaging shows evidence of bone destruction or abscessation. The results from the Istanbul study regarding surgical outcomes were very encouraging. They found that ventral bulla osteotomy, whether performed alone or in combination with traction and avulsion, was the most frequently used technique. Most importantly, they observed no recurrence in the cats treated with ventral bulla osteotomy during their follow-up period. This strongly supports the idea that while it is a more invasive surgery, it provides a very favorable long-term clinical outcome. Of course, no surgical procedure is without potential complications, and it is vital for veterinarians to set clear expectations with cat owners. Postoperative complications can include Horner syndrome, vestibular disease, and facial nerve paralysis. Interestingly, Horner syndrome appears to be more common after ventral bulla osteotomy, occurring in up to 80% of cases compared to about 40% after traction and avulsion. The good news is that for many cats, these neurological signs resolve within weeks to months. Other complications more specific to the ventral bulla osteotomy include incisional issues, wound drainage, or even airway obstruction, though these are less common. In addition to surgery, managing secondary infections is a critical part of the care plan. Because the tympanic membrane is usually ruptured when a polyp is present, veterinarians must be extremely careful to use medications that are safe for the middle ear. This often involves compounded solutions containing antibiotics like enrofloxacin and antifungals like meconazole, combined with a steroid like dexamethasone. Systemic antibiotics are also used, ideally chosen based on culture and sensitivity results from the middle ear. These medications are typically administered for 6 to 8 weeks to ensure the infection is fully cleared. As we wrap up our discussion on feline inflammatory oral polyps, there are several key points for every practitioner and cat owner to keep in mind. First, any young or mature adult cat with recurrent ear disease should be highly suspicious of having an inflammatory polyp. If you see blood in the ear, that is often a strong indicator of a mass. An otoscopic exam is mandatory for a proper diagnosis, and advanced imaging, specifically computed tomography, should be prioritized to determine the full extent of the disease and to check for bilateral involvement. Remember that over half of these cats may have polyps in both ears, and missing the second one can lead to continued suffering and the need for a second round of anesthesia and surgery. When it comes to treatment, the choice between traction and avulsion or ventral bulla osteotomy should be individualized based on the imaging findings and the severity of the case. While traction is a great first step, it often requires follow-up steroid therapy to be successful. For a more definitive one-time solution, especially when both compartments of the middle ear are involved, as they are in the vast majority of cases, the ventral bulla osteotomy remains the gold standard. Ultimately, the goal is to provide a comprehensive diagnosis and a tailored treatment plan that addresses both the polyp and the underlying inflammation and infection. By using the latest diagnostic tools and surgical techniques, we can significantly improve the outcomes for these feline patients and help them return to a life free from the discomfort and neurological challenges posed by these persistent growths. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.